about cervical spine clearance, and I think it's very important because in today's trauma surgeons, what's always crossing their minds when they're trying to clear the C-spine is that es tu cuello, pero es mi futuro, si algo pasa and I miss an injury. So most of the house officers and the fellows that I train are always very scared about clearing the C-spine because if they mess up, they're very worried about malpractice and not worried so much about the patient. And so I think this is a very good topic to have. What we're going to talk about today is really know the mechanisms, penetrating versus blunt, some of the anatomy, what are unstable fractures, who really needs imaging, and in the end, when all else fails, what are we going to do? So these are the sort of a lot of the data that comes out of crash scene sequences. The case vehicle information comes out of computers within the vehicles themselves. There's a recapitulation of mechanisms of injury within an enormous amount of databases, and all these informations from thousands of motor vehicle crashes actually come together into these databases to reconstruct certain injury mechanisms so that we can improve overall prevention of injury within these vehicles. Now, the reason that this is very important for us is really has to do with what we've discovered while looking at these mechanisms. If we take a look at this first video, you'll see, in fact, that with a lap belt, the C-spine has an inordinate amount of distraction, flexion, extension injury. And even if the shoulder harness in this particular model is inappropriately fastened, there's an enormous amount of distraction on the C-spine. Again, lap belt with no shoulder harness compared to the normal above. And you can see the difference in here above normal and without appropriate fixation, the enormous amount of distraction, flexion, extension injury on the C-spine itself. So, deficit. When a patient comes into us from a blunt motor vehicle crash, the most important part of the ABCDE in spine assessment and C-spine clearance really has to do with deficits. And there's an enormous amount of definition as far as spinal cord injury. We certainly know that spinal cord injury is an insult to the cord. It occurs in both blunt and in very rare circumstances penetrating injury. But we talk about in terms of tetraplegia, are the patients moving their limbs? Paraplegia, is it lower versus upper extremity? All these things need to be obtained in the primary survey because if you have an injury, then C-spine clearance stops. If there's any deficit that becomes positive during the examination, C-spine clearance stops, and then expertise is demanded. And that expertise comes from our neurosurgeons or our orthopedic surgeons. If there is a injury of the spinal cord, again, an extent of injury is defined by the Asia Impairment Scale, A, B, C, and D, depending on motor and sensory function. Other classifications depending on whether or not you have a central cord injury. You may have patients that come in that actually have injury, peripheral neuropathies, they're not able to grip, and the entire bony architecture of the C-spine is actually intact. The examination after the primary survey, when we're obtaining deficits during the secondary survey of trauma, is essential before we move on to clearing the C-spine, which is why I take the time to actually go through some of them here. Even Brown Sequards have been described in patients who have been stabbed in the neck. So it's very important to go through your methodology the way ATLS teaches, and when we get to deficits, we take our time to see whether or not there's neurologic deficits. We'll score these, and then again, we consult expertise. If there is no deficits, almost all trauma patients, at least in the United States, show up with a C-collar. There's some changing data as far as how we're going to clear these C-spines. The ability to clear these C-spines are very much dependent on the available equipment that you have. Do you have MRI? Do you have CAT scan? Do you have X-ray? If you don't, in the end, no matter how much resource you have, the ability to clear the C-spine is very much based on experience and judgment. I'm going to go through the EAST guidelines and then I'll terminate the talk because really what the discussion here is where are we at right now based on the modern guidelines for C-spine clearance. Early removal of cervical collars may be associated with decreased collar-related decubitus ulceration, decreased intracranial pressure, fewer ventilator days, fewer ICU days and hospital days, and a decrease in the incidence of delirium and pneumonia. There's a very big reason for us in trauma to take these collars off of our patients. We've even, as I said, described an ability to reduce intracranial pressure by allowing the anterior portion of the collar not to compress the jugular veins. It's essential that we do everything we can to remove these collars of our patients. Again, the lines of alignment, when we look at CAT scans and even plain films, depending whether or not people are still obtaining them, there are 3 lines of alignment: the anterior laminar line, the posterior laminar line, and the interlaminar line. Dennis's actually describes 3 columns of stability, which is a rule that we use. You have the anterior column, the middle column, and the posterior column. If on radiologic assessment, either through CAT scan, which is what we consider the modern approach to C-spine clearance, or even plain film, if 2 of these columns are disrupted, and again, there's a bilaterality, so you have 2 anterior columns, right and left. If they're both disrupted, the C-spine is considered radiologically unstable, and at that point, clearance stops and we obtain expert consultation. The C1 and C2 on CAT scan are incredibly complex. There's an enormous amount of ligamentous and motion that is obtained from these 2 vertebrae. And when we assess them, the C1 is actually very much dependent on the intact ring itself from the vertebrae. A Jefferson fraction that you see depicted here is actually defined as stability by the rule of Spence. If you add up all of the distances within these fracture points, and they're added up on CAT scan, the rule of Spence dictates that if that space is equal to 7 millimeters or more, adding each one up, then radiologically that fracture is unstable and expertise needs to be obtained and we cannot take the collar off. Hangman's fractures are considered to be unstable until assessed by C-spine experts. But again, you can see that readily mostly in blunt verticular accidents, the C2 vertebrae again has the classic Hangman's fracture, which is also considered unstable. We can see unifacet disarticulation on C-spine when we look at CAT scans. These are all the different types of fracture patterns that once we address imaging in order to clear the C-spine, we're going to be looking for as we continue our imaging triage. Double facet dislocations, teardrop fractures anteriorly are also very important. They denote an enormous amount of flexion extension injury. I'll use this as a moment to tell you that in the lateral sagittal reconstructions, either on CAT scan or plain film, if there's a loss of height of more than 25% of the vertebral body, that is also considered radiologically unstable. So as we move into imaging to try to clear this collar, you can see there's an enormous amount of information that we can obtain from our radiologic imaging in order to decide whether or not, in fact, the fracture pattern of the C-spine is unstable. If it's unstable, then the collar does not come off. The East guidelines say removal of cervical collar. Cervical collar should be removed as soon as feasible after trauma for all the various reasons that we've discussed already today. In the patient with penetrating trauma to the brain, immobilization of a cervical collar is not necessary unless a trajectory suggests direct injury to the cervical spine. And this is very important. Unless you have a direct injury to the spinal columns with a bullet, which normally speaking can only occur in a completely lateral trajectory through 2 columns within the C-spine vertebrae itself, it is incredibly rare for any type of penetrating trauma to actually create an unstable fracture of the C-spine. It may hit a transverse fracture, it may hit the vertebral body, but again, in penetrating trauma, the chances are extremely rare that you have an unstable fracture of the C-spine. Why is that important? When you've applied imaging and you've done everything you can for someone with penetrating trauma and you're still left with a cervical collar, the opportunity arises where, again, experience and judgment is going to allow us to take that collar off for all the reasons that we discussed, including ICP elevation, decubitus ulcer formation. That collar and penetrating trauma is going to come off unless there's a complete disruption of the vertebral columns with that missile, which is extremely rare. Dense fractures, C2, again, the types of type 2 and type 3 dense fractures are considered unstable, and these also denote, we're going to be looking for them in our imaging, but again, they denote a need for consulting higher expertise. And the dens of the C2 fractures, again, as everybody knows in the audience, type 1, type 2, and type 3. In awake alert trauma patients without neurologic deficit or distracting injury who have no neck pain, again, on exam we elicit no midline tenderness, no rotatory tenderness, with full range of motion, C-spine imaging is not necessary and the cervical collar may be removed. There have been two valuable studies, the Canadian C-spine rule study and the Nexus. If there's one paper that you pull out and read, it's the 2003 New England Journal of Medicine that compared these two criteria for examination and clearance of the C-spine. What we know now is that even if you're mildly intoxicated, if you're able to create an exam, if you have full range of motion and no midline tenderness without distracting injuries, that collar can come off without imaging. And we do that for an extended period of time in the United States, and we've had no problems. The Canadians have done it, and they've had no problems. The risk of missing an injury, again, if the exam is completely normal and the patient's awake and alert with no distracting injuries, is extremely rare. In all other patients in whom C-spine injury is suspected, we must obtain radiographic evaluation. This applies to any patient with tenderness on exam, any patient who has any of the neurologic deficits that we described, any patients with altered mental status, and patients with distracting injuries. All of these must undergo secondary imaging in order to evaluate the C-spine for fracture before that collar can be removed. Primary screening modalities in the United States, right now, the EAST guidelines denote axial tomography or CT scanning from occiput to T1 as the standard of care for what needs to be performed in order to clear that C-spine. Plain radiographs based on data from the United States contribute no additional information and should not be obtained. This is a recommendation from the EAST guidelines group if you have the ability to do tomography. If you have the ability to do CT scanning, the assessment based on prospective level 2 data, not randomized control, but level 2 data, is to not perform plain radiography, but to move on to axial tomography from occiput to T1 with reconstruction in order to take a look at the C-spine vertebrae. If CT of the C-spine demonstrates injury, spine consultation is obtained. Again, through all the different fracture patterns or assessments that we've described, if there's a fracture that we consider to be unstable, spine certainly is going to be consulted. In some trauma centers, any fracture gets a consultation from spine. It depends on the environment in which you work. If there is a neurologic deficit attributed to a C-spine injury, you must obtain expert consultation. If we denote, even though you're getting the CAT scanning, you have the fracture pattern denoted. If there's a deficit, spine expertise from a surgical consult must be obtained because you may need to decompress that spinal cord. In the end, if we do have a neurologic deficit and we do have a fracture and we're not running emergently to the operating room, the majority of recommendations, as they are here in the EAST guidelines, is to obtain an MRI in order to further elucidate the injuries associated with that fracture. For the neurologically intact, awake, and alert patient complaining of neck pain with a negative CT, we continue cervical collar. We could obtain cervical collar and then take the patient to MRI, or we can remove the collar after negative flexion extension films. It all depends on what you have available in your institution. For the neurologically intact patient who's complaining of neck pain in the United States, they're going to get an MRI. The majority of patients of centers are no longer doing flexion extensions, but again, if that is what you have available, as the EAST guidelines denote, you may remove the collar after adequate negative flexion extension films. Now, we performed a study that was published in the Journal of Trauma that took a look at actually performing an examination of the flexion extension of a patient prior to going to radiology. And people with midline tenderness, you would then examine them before they went to radiology, and you must obtain a flexion based from tragus to nair of at least 30 degrees in both flexion and extension. 30% of trauma patients actually failed to perform an adequate flexion and extension. Because of this, MRI is actually used for the majority of the time because it normally takes 2 hours. A member of the trauma team has to go with the patient. They have to go down to radiology. They have to remove the collar. They're the ones that are in charge of doing the flexion extension while the radiology. And in a time motion study that we performed, on average, that takes one person of the trauma team out of commission for 2 hours. And to waste 2 hours for a 30% inability to perform test, we felt it's much more pragmatic to just send the patient to MRI and get an MRI performed. But flexion extension films are still considered adequate based on EAST guidelines.
For the obtunded patient with a negative CAT scan and gross motor function of extremities, flexion extension radiographs should not be performed. The patient needs to be able to complain of pain. I certainly went through the period of time where we were doing fluoroscopy, looking for mild vertebral motion in patients who were obtunded. We're not going to do that anymore. And certainly the EAST guidelines reflects that. The risk-benefit ratio of obtaining an MRI in addition to CAT scan, it's not clear, and its use must be individualized in each institution depending on your resources. You can continue cervical collar immobilization until a clinical exam can be performed. Again, I don't necessarily recommend that, but that can be performed if you don't have the resources for MRI. You can remove the collar on the basis of CT scan alone if there's no fractures. There is some data that if the CAT scan is completely normal, even though there's a small risk of ligamentous injury, that risk may be between 1 in 5,000 to 1 in 10,000, depending on which study you look at. Some people, based on the environment they're in, are willing to accept that based on experience and judgment, and the discussion is just made with the family of the patient who's obtunded that we're going to remove the collar, again, for all the reasons that we discussed. In North America, we're going to obtain an MRI. We have the ready resource. We're going to go after ligamentous injury, even though the fractures are never, and we're going to look at it. Now, one caveat that I will give you is that MRI, as we do know, works on dipole moment of water molecules. In the acute fracture of a vertebrae in the C-spine, there's going to be an enormous amount of water and edema. If the MRI is obtained 48 to 72 hours after the acute fracture, it may miss ligamentous injuries because you no longer have the same amount of edema. So the sensitivity of an MRI to pick up ligamentous injury for a C-spine fracture actually goes down the longer you wait to obtain that MRI, which is why we obtain it as soon as we do. If you go out past 72 hours, that sensitivity really drops off. If MRI is negative, again, the cervical collar may be safely removed. This is a level 2 EAST guideline recommendation. There is valuable data that says that this can be done from an evidence-based approach, although there are no randomized controlled trials. I will finish again saying that in regards to the use of Fluoroflex X, and I've spent a lot of time in South America, we used to do this a lot. I don't know if you're doing this now in your institutions, but certainly I have employed this over the last decade and a half of working here. In my opinion, from review of the literature, I've concluded that this shall no longer be performed in the obtunded patient. From speaking to spine radiologists, to spine experts, it's just impossible for us as clinicians to be doing fluoro and actually see the 2 to 3 millimeters of motion that is the minimum that is acceptable before you have an injury. If you have a completely unstable C-spine from a ligament point of view and you're trying to see motion of more than 2 or 3 millimeters, you may actually make the injury worse. So I recommend not doing that and trying to attend an MRI if at all possible. If you can't, then you use your plain radiographs. I mean, we did them for years. If you do not have the ability to use CAT scan, if you do not have MRI, for years we used our 3-view C-spines with oblique or swimmer's views in order to obtain the C1 through T1 delineation of vertebral alignment, and there's nothing wrong with that. If that's the resource you have, it's to be applied, and we just know from discussing it with the family and the patients and your colleagues that there are going to be a small percentage of fractures that will be missed on plain radiographs, but those are the resources that are available in your environment. These are algorithms that I think things can be protocoled based on evidence. MRI is used here, CAT scan is used here, and certainly everybody should develop a protocol. That way the entire trauma team is on the same page based on the evidence of how you are going to perform C-collar clearance in your institution. There's advents of new technology. This is a conventional head restraints in the lower part of the panel, and in the upper part of the panel you see actually active restraint mechanisms that are being studied in order to reduce the incidence of C-spine injury with rear impact or forward impact motor vehicle crashes. Again, thank you very much. I appreciate everybody's help. These are my partners who are staying at home and fighting the fight while I come here and enjoy the beautiful Medellin, Colombia. Thank you very much.